With the last class, this was a last slide we have seen the DSM-5 criteria, which classifies the sleep disorders into different things. And the next classifications we talked about here was the the ICD classification, ISDS. This was the classification, ICD-10 classification. So this is International Classification of Disease. You can see this class of classification is given a lot of coding. You can see the numbers are given. So this is a classification used for in the medical coding as well. According to this classification, the sleep disorders are classified into different way, like disorders of initiating and maintaining sleep, that is insomnia, disorders of excessive somnolence, that is hypersomnias, or disorders of the sleep-wake schedule, sleep apnea, narcolepsy and cataplexy, this is daytime sleeping, and other sleep disorders, sleep disorder unspecified. So this is how the ICD-10 classification classifies the sleep disorders. And you can see there is a particular code given for each thing. Okay, so this is the any kind of in pharmacovigilance or any kind of coding, no, this classification is widely used, ICD classification. The other classification is International Classification of Sleep Disorders, like ICSD. It's a third version. So in this classifications, again, sleep disorders are classified as insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnia, sleep-related movement disorders, and other sleep disorders. So this is how the classified the sleep disorders as per this classification. So now we are seeing like different classifications of sleep disorder as per three different criterias. Now we'll go to the individual criteria, individual sleep disorders. So in this chapter, we'll follow the DSM criteria of classification. So as per DSM criteria of classification, insomnia disorder is the first type of sleep disorder. So what is insomnia? Okay, so it's very simple that it's going, it's initiating and maintaining. You can also say that dissatisfaction with sleep. So any person who are not satisfied with the quality of the sleep, not satisfactions, then also characterized by difficulty falling asleep. Okay, so you can see that a lot of people they will not get sleep, they walk here there and do some activities to get sleep, but still they will not get the sleep. So whatever you do, you're not getting sleep. Okay, and even after awakening during the night. Okay, so that's also is known as insomnia. And there is also quantitative criteria to include the frequency. When we call it as insomnia, see, few days we may not get even normally, for few days, for 5 weeks at least may not get. So that's a common thing. But here, if we don't get sleep for at least 3 nights per week, in a week, 3 nights, and this duration is at least for 3 months. So for 3 months, at least 3 nights per week, if there is a difficulty in falling asleep, then we call it as insomnia disorder. So this is the criteria for classifying it as insomnia. So here you can see that is diagnosed when the sleep problem is not better explained, mainly does not occur exclusively during the course of or another mental, medical or sleep disorder. And it's also not attributable to any physiological effects of drug or medication. So anywhere, if anything that happens Okay, so some may not get sleep, and also any due to medications. If it is not there, then we can does not call it as insomnia disorders. Okay, and also it's accompanied by symptoms of physical or cognitive, or most of the time hyperarousal. Many times, frequently during the night, bedtime, there is a arousal, wake up, and also muscle tension, inability to relax, and feeling more awake after going to bed. These were the few symptoms usually accompanies in the insomnia disorder. So seeing the epidemiology of insomnia, it's a very common, most common disorders. Among all sleep disorders, insomnia is very widely the occurrence, it occurs very widely. You can see that around 30 to 50% of the adult population, they can experience the insomnia during any course of a year. And if you see the male to female ratio, see males are more much affected. So it's almost 1.5 years, female is 1. So it's almost higher in the males. And the age effect is not universally observed. So any age of the thing, and usually the older age people will suffer from this more commonly. But still the adult age also would get affected. You can hear me properly?
Yes, yes, sir.
sir.
Huh?
Yes, sir.
Okay. So,
Yes, sir.
okay, the medical disorders which are associated with insomnia, there are few conditions, diseases which contribute to the insomnia, like CHF, COPD, asthma, chronic renal failure, any prostatic hypertrophy, any GI reflex diseases, GRD, fibromyalgia, osteoarthritis, rheumatoid arthritis, hyperthyroidism, diabetes. These are Parkinson's, cerebrovasculars, and menopause. So these are all the 5 acute important diseases which usually impact in causing the insomnia. And there are also some psychiatric disorders along with the other diseases like major depression, dysthymic disorder, bipolar disorder, GAD, panic disorder, post-traumatic stress disease, schizophrenia, any kind of substance use disorders. So these are all the few psychiatric disorders which causes insomnia, and also medications that causes insomnia. I think I told I've given a question no on this.
Yes, sir.
Yes, sir.
It's done now.
Yes.
Yes, sir.
So which are all the medications which cause insomnia?
Dopamine agonists, anticonvulsants, medicines given for cold, steroids, beta agonists,
Theophylline.
theophylline diuretics,
Uh,
niacin, caffeine, appetite suppressants,
Amphetamines,
uh,
Statins, dopamine,
steroids,
okay,
antihistamine.
okay. So we have a lot of medications which causes this insomnia disorders. We can see that alcohol, acute use or withdrawal, caffeine, nicotine, cannabis, antidepressants, corticosteroids, beta agonists, theophylline derivatives, beta antagonist, statins, stimulants, and dopamine agonist. So few of these medications, which you can see this kind of medications are all more of excitatory in nature. So because of these excitations, they may cause insomnia. And also same way, the genetic factors also involved in this insomnia. So you can also clearly observe in monozygotic twins and also first degree family members. So it's also the genetically inherited, we can say, the insomnia. So genetic factors are also involved here, causing because in the twins we can observe, and also in the first degree family members, and also neurobiological factors also is associated with this, like physiological hyperarousal. Also patients with the insomnia have increased whole body metabolic rate, and also increased cortisol level. This is a very important thing, the cortisol. We can see that the cortisol is also plays one of the role in maintenance of the thing in the sleep. You can see that the cortisol ACTH, they increase particularly in the evening and early sleep hours. Because of this, the alertness increases. So cortisol should usually get released in the early morning, which helps maintains the awakeness. But here in the evening, if it comes in early hour sleeps, then the person cannot go to sleep. Also here altered heart rate variability will be there, and also altered secretion of norepinephrine and cytokines are there. So these neurobiological factors also will involve in causing of the insomnia, and also psychological factors, as I say, like many issues like depression and anxiety symptoms always leads to insomnia, and also social environmental factors. You have doesn't have good day, or you have some quarrel with some other person, or you are not performed well, or some other thing, or environmentally also any sound pollution, noise pollution, the sleeping place is not comfortable. So all this also can leads to the causing the insomnia. So coming to the management of this disease, treatment goals. So the main treatment goal is to improve qualitative. So qualitative in sense like what is the duration of the sleep, nice sleep, that is REM sleep, and also the quantitative aspects of sleeps, how long you sleep. Okay, and also to reduce sleep related distress, and also improve the daytime function. These are all the three main goals for any treatment. And for any somatic treatments, as we know, a lot of neurotransmitters are involved in uh, maintenance of the sleep. Here, the somatic treatments, lot of pharmacological drugs are approved. We have discussed very lot in the previous diseases also. You can see that benzodiazepine receptor agonist. So we have alprazolam, diazepam, lorazepam. Okay, so clonazepam. A lot of drugs are there. And also tricyclic drugs like amitriptline, and very specifically here for insomnia, these are the special kind of drugs like melatonin receptor agonist. There are very new class of drugs which they use for insomnia, like Ramelteon, Agomelatine, and dasymilertina. So these drugs are approved by the FDA, and very recently they have in the market. And the antihistaminic like proprazine and also barbiturates like phenobarbital also is used as a pharmacological treatment in insomnia. See, I think all these drugs dosage, another mechanism, adverse effects, and contraindications uh, you have to collect, okay, from the other sources. Okay.
Yes.
Yes, sir.
Yes, sir.
Okay, psychosocial treatments also are there in the treatment of insomnia. They're like stimulus control. There is also sleep restriction therapy, relaxation training, cognitive restructuring of irrational sleep-related beliefs, and sleep hygiene. So these are all the few social this for the management of insomnia. And also sleep hygiene has to be maintained for any kind of to get the sleep. So like any behavior that cause harm to sleep has to be avoided. Like avoid naps, get regular exercise, maintain a regular sleep schedule. This is, as I told, like one particular time you have to fix daily for the sleep. And also you should avoid stimulants, caffeine and nicotine, especially just before the sleep, and limit alcohol intake also. And so do not look at the clock when awake in bed. Okay, so that itself give a psychological feeling that you have time to sleep or there is no time to sleep. Okay, so that's all about the insomnia. The next uh, terminology in the sleep disorder is narcolepsy. So this is, we can see, like very frequently heard of this. It's nothing but it's a extreme daytime sleepiness. So even we see like people sleep in the daytime very frequently. And also this narcolepsy is many times is recurrent, especially irresistible need to sleep. And also unintentional sleep episodes or napping. So this is also, if it is there 3 times per week for at least 3 months, all these as symptoms are seen means then it is a narcolepsy. And also apart from this, they also required one of 3 additional findings for to diagnose as narcolepsy. That is episodes of cataplexia. This is nothing but it's a sudden and bilateral loss of muscle tone. Okay, with preserved consciousness. You will be preserved but muscle tone. That's what you fall. Okay, daytime sleeping. If you sleep, that we can see that people will be sitting, okay, listening for something, again get sleep and just fall. Okay, that's a loss of muscle tone. So when there is no muscle tone, then only the people fall. Okay, so it's also precipitated by strong emotions, sometimes laughter. And also there is hypoprotein deficiency in cerebrospinal fluid. And also polysomnography findings are seen specifically, like reduced latency to REM sleep, especially in the nocturnal this one, that is 15 minutes or less. The REM sleep in the night time will be 15 minutes or less. So actually, as I told, like a good sleep means like if it is more time spent in the REM, then the better the quality of the sleep. But here the REM time spent is 15 minutes or less, very less. So because of that only this narcolepsy can occur. So night you will not get good sleep. So that will be compensated in the daytime. And also the narcolepsy is associated with hallucinations at sleep onset, like hypnagogic or sleep offset, hypnopompic, 20 to 60% of patients. Okay, so onset and offset. So they starting is a sleep and onset. Hallucinations also can occur. And also paralysis also can occur, sleep paralysis at onset or offset. It's also typical narcolepsy, and a lot of episodes of alertness, inability to move with skeletal muscles can occur. And also nightmares and vivid dreams also occur very frequently with the narcolepsy. The prevalence is very less, unlike like the insomnia. It's around 20 to 50%, but here is 0.2 to 0.4%. But still, it's kind of chronic and persistent in people who have been with that. Coming to the causes, the etiology and pathophysiology of narcolepsy. Again, this also is genetically dependent. You can say that can see there is a strong association with HLA marker like DQP1 star 0602. This is the gene responsible for the cause of the narcolepsy, and also neurobiological factors also involved, like other. And you can see that the deficiency of hypoprotein, that orexin, we have seen that in the pathophysiology of overall sleep disorder. The deficiency of this, the hormone, and also the postmortem. This one show that loss of orexinic cells and reduced orexin immunoreactivity in the lateral hypothalamus (LAT). So that's what we know. Like there is a awake switch and sleep promoters. So both will have get having problem with the maintenance of the sleep. The treatment of this narcolepsy is goals is reduce daytime sleepiness and manage symptoms of cataplexy and muscle tone, loss of muscle tone, also sleep paralysis. Okay, I'm back. Can you hear me now? Okay.
Yes, sir.
Again, the treatment, somatic treatments, pharmacological is monoaminergic stimulants are given here, like methylphenidate, dextroamphetamine, and also mixed amphetamine salts are used, and modafinil and armodafinil. I think you can remember modafinil now. Even they give in the wards also modafinil uh, to reduce the daytime sleep. And atomoxetine, bupropion, anti-cataleptic drugs like venlafaxine, desmethylvenlafaxine, duloxetine or fluoxetine, and also tricyclic antidepressants. These are all the drugs which are usually used for the treatment of narcolepsy. And also psychosocial treatments. So brief nap, scheduling regular brief nap can be done as a psychosocial treatments. And the doses of these drugs you can just refer another. The other disorder now is hypersomnolence disorder. It's nothing but it's excessive sleepiness even if you have normal sleep duration at night. So even the narcolepsy is different, you will not get good sleep on the night, the daytime sleeping. But here, even though you get good sleep on the night, that there is a excessive sleepiness. So this is how we classify is mainly the repeated episodes of sleep during daytime hours. So you have prolonged nightlife sleep, especially like 9 plus hours, more than 9 hours. And even though you have 9 plus hours of sleep in the night, again difficulty transiting from sleep to wakefulness. So even 9 hours, 10 hours, if you sleep 12 hours also, you are unable to wake up. But usually body does not need so much of long rest. Usually they say like 8 to 9 hours or even good sleep of 5 to 6 hours is enough. But here, even though sleeping even more than 9 hours also will not be waking up. And even that during that time we find very difficult. So that's known as like sleep inertia. So again, this should be at least 3 days per week for at least 3 months for the classification. And also significant distress or impairment in important daytime functions can be observed. And this is the prevalence also is very less, 0.05 to 0.6% in Western populations. And comorbidly, like any autonomic dysfunction, especially orthostatic hypotension, no, you are unable to wake up. When orthostatic hypotension change in your positions when standing up, the BP will be low. So you feel like does not like to stand. So that's the one of the another comorbidity also will cause in this kind of hypersomnolence. And depression is also sometimes common. So it's equally seen in both men and women, and it's also the onset in the second and third decade with chronic persistent causes are more common. There are also different types of hypersomnia like Klein-Levin syndrome, menstrual related, any kind of hypersomnia, idiopathic, doesn't know the reason. That's the hypersomnia. Also behaviorally induced insufficient sleep syndrome and hypersomnia due to a medical condition. Okay, so that's also one of the reason for the hypersomnia conditions. And also the hypersomnia due to drug or substance abuse, substance use, the drug induced the hypersomnia. Again, this also is genetically influenced. You can see that there is almost 50% of cases have familial predisposition. So it's a suggestion of autosomal dominant inheritance and also 24-fold risk in first degree family members. And also neurobiological factors, a lot of monoaminergic arousal systems have been showed that there is a reduced CSF, dopamine and norepinephrine metabolites. So these are all the few excitatory which helps in the awakening of the person. So the reduced concentration of this neurotransmitter will cause these hypersomnolence. The treatment goals is again there is the impact of long night time sleep and excessive daytime sleepiness. So drugs used here is again monoaminergic stimulant, same like narcolepsy, like methylphenidate, dextroamphetamine, and mixed amphetamine salts. And modafinil also is used, and armodafinil, and atomoxetine, and bupropion are also used. And psychosocial treatments also commonly seen here. Setting regular sleep wake schedules and using multiple alarms, including social interactions or bright light, so also may help to reduce the sleep wake transition. And the other class of disease like breathing related sleep disorders. So this is what again because of the breathing issues, as you know, like the sleep disorders occurs. The obstructive sleep apnea, hypopnea, and central sleep apnea, and also sleep related hypoventilations. These are all the three subclassification under this. So all because the breathing is affected in the sleep disorder, so there is a hypoventilation occurs. So impaired ventilation, so decreased oxygen supplies in the body. So it also leads to intermittent or sustained hypoxemia and also sleep disruptions that leads to awakening as well as daytime sleepiness and fatigue can occur. So this is when we call it as is any airflow reduction that lasts for 10 seconds. Okay, that is classified as either apnea, that is absent airflow because your person is not breathing, so the airflow is not there for at least 10 seconds, or hypopnea, that is reduced airflow because of maybe fully air may not enter, that is absent, that is apnea. Hypopnea is reduced airflow, decreased things. And the frequency of these events per hour of sleep, there is an index called as apnea hypopnea index. So they calculate about this AHI. So they measure the AHI, the ratio of these two, and this is an important measure of the checking the severity of OSAH and CSA. OSAH is nothing but obstructive sleep apnea, hypopnea, and also central sleep apnea. So this AHI index is one of the important standard measure to know the intensity of the sleep. So first is the obstructive sleep apnea. It's most common. So mainly problem here is the pharyngeal airway obstruction. It is done very repeatedly. And diagnosis is again in the absence of symptoms, polysomnography is to document at least in the AHI of 15 or AHI of more than 5 with predominantly obstructive respiratory events. And also there are a lot of symptoms which accompanies like nocturnal breathing disturbances. You'll have snoring. Snoring is one of the important thing where it blocks the air also. That's why the sound during the snoring get a very weird sounds. Okay. If it is the air usually passes without any obstruction, then there will be no snore or sound. But when the air is obstructing, only that sound will come, like snorting, gasping, and also breathing pauses. And because of this, you'll not get good sleep. Then the daytime sleepiness also will occur, fatigue, and unrefreshing sleep despite sufficient sleep opportunities are there also. There is daytime sleepiness. And along with this, there is also habitual snoring is also sensitive indicator, and increasing loudness of snoring associated with higher risk. And also snoring may be interrupted by silent periods like apneas, which we terminated as resuscitative breathing. And also memory disturbances, poor concentration, irritability, and personality changes can also occur because of these issues. And also because this is the thing like other sleep disorder, you can know that it only affects the sleep. But here the whole the oxygen level in the body also is reduced in this kind of sleep disorder. So since because of that, there are multiple organs are affected, and also the other clinical manifestations like hypertension, heartburn, nocturia, morning headaches, and sexual dysfunctions. So all this can cause in this kind of disease, and very predominantly seen in age more than 55 years, specifically in males. Even the BMI is also important. So more than 30. So people who are heavy, they are more commonly have to have this. And neck circumferences, so more than 16 inches in women and more than 17 inches in men. So they are all have higher risk of the getting this thing. And here the female to female, the male to female ratio. So male are not much affected, females are more. Okay, you can see 2:1 to 4:1, male, the female. The treatment goals mainly improve symptoms and quality of life and minimizes risk of comorbidity. And the treatment here is more of not of more of drug therapy is not much there, but there is also a system called continuous positive airway pressure. There is like a devices type. They put it on the nose, and the mandibular advancement devices. So this devices helps the pharyngeal place where the constriction takes place and the movement of air causes noise. So it will usually dilate that place, so the air enters easily. And also surgical procedures like uvulopalatopharyngoplasty also can be done for this kind of snoring issues. And also psychosocial treatments like weight loss, avoiding the supine sleep position, reducing evening alcohol consumption, and getting adequate sleep duration. These are all the few other psychosocial treatments that avoiding the supine sleep position could also be one of the very important thing. So when a person sleeps flat, there is a chance of more obstructions in the pharyngeal. So if it is made to sleep on the side wise, this kind of issues can be tackled very easily. Any questions here?
No, sir.
No, no, sir.
So these
No,
are all
sir.
the okay. So next